Artificial intelligence and traumatic brain injury. Welcome to today's presentation on artificial intelligence and traumatic brain injury. The intersection of AI and neurotrauma is rapidly evolving, offering powerful tools for diagnosis, treatment, monitoring, and rehabilitation. As clinicians, researchers, and educators, it's crucial that we understand how these technologies are reshaping our field. In this talk, we'll explore how artificial intelligence is being applied across the neurotrauma continuum, from early triage and diagnostics in the emergency setting to long-term rehabilitation and outcome prediction. We'll also highlight some of the ethical and clinical considerations that arise when integrating AI into patient care. Our goal is to critically examine the evidence, understand current capabilities, anticipate future directions, and identify practical implications for bedside care. We'll begin with a case presentation that raises questions about the actual and potential role of AI in traumatic brain injury care. Case: Artificial intelligence in traumatic brain injury. A 90-year-old woman living independently is found down after an unwitnessed fall. She arrives in the emergency department with a Glasgow Coma Scale score of 4 and one fixed dilated pupil. CT imaging reveals a large holohemispheric frontotemporoparietal acute subdural hematoma with 1.5 centimeters of midline shift. Question: do we monitor intracranial pressure alone or proceed immediately with emergency decompressive hemicraniectomy? The family is en route, but is not yet aware of the CT findings, their loved one's prognosis, or the potential risks and benefits of surgery versus conservative management. Question: can artificial intelligence assist with synthesis of clinical data, prognostication, and with communication of options to family members that is both timely and compassionate? After the family arrives and gives informed consent, the team decides to proceed with emergency surgery. At the end of the hemicraniectomy, the brain is not swollen. The dura could be closed and the bone flap fixed back in the skull, but likely over time, the brain will swell and intracranial pressure will go up. Question: should the bone flap be replaced? Can AI models help intraoperatively by providing predictive risk assessments based on similar cases and multimodal data inputs? An external ventricular drain that can also monitor intracranial pressure is placed in the OR. The patient is transferred to the ICU for postoperative care. Despite aggressive management, her GCS remains 4 at 24 hours post-op. After 1 week, there is still no improvement, and she has developed pneumonia. Neurocritical care agrees that her prognosis for meaningful neurologic recovery is poor. Questions: can AI help the neurosurgeon and neurocritical care team with evidence-based best practices recommendations about continued treatment versus withdrawal of care? Can AI tools help families navigate end-of-life decisions, including the possibility of donation after circulatory death, by providing prognostic clarity and emotionally intelligent support? This case will frame our discussion today, one that touches every phase of care, from triage to surgery to critical care, and ultimately to communication and ethical decision making. Questions about AI and TBI raised by the case are in the notes section of the following slide. AI and TBI topics. Introduction. Before discussing actual and potential applications to neurotrauma care, we'll begin with an introduction to artificial intelligence. What is artificial intelligence? How is it created? And how does it work? AI applications in TBI care. Once we understand AI basics, we'll consider some of the applications of artificial intelligence that supplement, assist, and support clinical decision-making and care, including diagnostics with faster, more accurate imaging and detection, personal care with customized treatment and neurostimulation, real-time monitoring for predictive alerts and continuous tracking, AI-driven robotics, increasing precision in TBI neurosurgery, neurorehabilitation, adaptive motor and cognitive therapies and brain-machine interfaces, prevention, early detection and intervention, and injury avoidance, brain health enhancement, cognitive optimization, and neurofeedback. Ethics. As AI is applied to neurotrauma critical care, developers and trainers need to remember the importance of human values in direction, training, and control to ensure that AI is humane and respects ethics. Introduction to artificial intelligence. Before we talk about applications of artificial intelligence in TBI care, let's briefly explain what AI is. Artificial intelligence means teaching machines to learn, not just to compute, but to improve with experience the way humans do. Artificial intelligent machines can now perform tasks we used to think only humans could do, like recognizing images, answering questions, and making decisions. AI systems are built on neural networks inspired by the brain's structure. We use artificial neural networks, digital versions of neurons that pass signals to one another along axons and dendrites and across synapses, just like the brain's own cells. They adjust their synapses based on right or wrong predictions. These systems train by adjusting their connections every time they make a mistake, just like a resident or nurse learning from experience. In medicine, AI learns from big data sets, also called metadata. For example, from millions of head CT scans, daily lab results, or vital signs during an entire neuro ICU stay. Some AIs, like ChatGPT, are called large language models. These are trained by reading billions of words and documents, learning to recognize how language is structured. They don't understand like we do, but they learn what usually comes next, which turns out to be incredibly useful for summarizing, translating, or generating medical reports. In addition to learning, generative AI systems can create. They can draft text, simulate outcomes, and suggest next steps in evolving processes. In healthcare, this might include drafting discharge summaries or suggesting treatment plans. One of AI's biggest strengths is speed. AI models can analyze more data in 1 second than most teams could in a full shift. And things are moving fast. The latest AI models are beginning to train themselves, requiring less and less human supervision. They're not replacing us, they're enhancing our ability to process complex data and respond quickly. But it's also important to remember that AI is not human. It doesn't feel, reflect, or understand ethics the way we do. Human oversight, especially in trauma and critical care, will always matter. AI can be biased, limited, and unaware of context. That's why human intelligence, emotional, ethical, and clinical, remains essential. Enhanced diagnostics in TBI, role of artificial intelligence. In the acute evaluation of traumatic brain injury, time is brain, and artificial intelligence is transforming how quickly and accurately we assess patients. AI-powered imaging. AI-powered tools can now assist with rapid analysis of neuroimaging. AI algorithms analyze CT, MRI, and PET scans with unprecedented accuracy, detecting hematomas, midline shifts, cerebral edema, and skull fractures, as well as subtle abnormalities like microhemorrhages or diffuse axonal injuries that may elude human eyes. These tools can flag urgent findings in real time, prioritize studies in the PAC system, and standardize interpretation across providers and institutions. A recent study in World Neurosurgery 2024 demonstrated that AI tools improve diagnostic accuracy in complex TBI cases and accelerated clinical decision-making by synthesizing imaging with physiologic data and clinical scoring systems. For example, AI-based systems like QER for detecting intracranial hemorrhages within seconds. Predictive analytics. Machine learning models predict outcomes for brain injuries based on massive data sets. For example, risk of secondary injuries from brain swelling or seizures, and recovery timelines and prognosis. In Neurocritical Care 2024, another study focused specifically on predicting intracranial hypertension. Using real-time patient data streams, including intracranial pressure, cerebral perfusion pressure, vital signs, and trends in neurologic exam findings, AI models could forecast critical pressure crises hours before they occurred, offering a window for preventive intervention. This predictive capacity is not just theoretical, it's clinically actionable. For example, a patient with a mild TBI but subtle imaging findings could be flagged as high risk for deterioration. AI tools can help guide decisions about ICU admission, monitoring intensity, or early neurosurgical consultation, even in centers without subspecialty backup. AI diagnostics are not limited to radiology. Advanced algorithms are now being trained to interpret clinical notes, labs, waveform data, and even pupillometry trends, creating a composite risk score that reflects the full picture of injury and recovery trajectory. For students and nurses, this technology offers real-time education as well, explaining imaging findings and likely diagnoses as part of clinical workflows. For families, these tools can help communicate complexity in understandable language. However, it's critical to remember that AI should augment, not replace, human expertise. Like any diagnostic tool, it's only as good as its data inputs and clinical contexts. Neurosurgeons and critical care providers remain in command, applying judgment to determine whether the AI's insights are relevant and actionable. Finally, as models improve, transparency and validation will be essential. Black box predictions must be interpretable if we are to trust AI as a partner in care. This is especially true in ethically charged decisions where accuracy, explainability, and accountability must go hand in hand. Personalized treatment plans, AI in precision neurotrauma care. Artificial intelligence is helping move traumatic brain injury care from protocol-based to precision-based, tailoring treatments to the individual patient in real time. Traditionally, we've relied on broad categories, mild, moderate, and severe TBI, to guide interventions. But every brain injury is different. AI enables us to stratify patients based not only on GCS or imaging, but on hundreds of dynamic variables: age, comorbidities, genetic markers, physiologic trends, imaging phenotypes, and response to initial therapy. One area where this is most visible is in protocol optimization. For instance, AI can identify patterns across thousands of patients to recommend when to escalate therapy. From conservative monitoring to hyperosmolar therapy, barbituric coma, or surgical decompression. These recommendations are not static. They evolve in real time, adapting to the patient's physiology and response to treatment. Precision medicine also extends to neurostimulation. AI can help determine which patients might benefit from transcranial magnetic stimulation, deep brain stimulation, or vagus nerve stimulation based on brain network mapping and injury localization. These technologies, while still emerging, hold promise for recovery of function in select patients with prolonged disorders of consciousness. Another frontier is individualized pharmacology. AI models are being developed to predict a patient's response to anti-epileptics, antidepressants, or even sedation regimens based on genomics and dynamic drug response patterns. This could reduce trial and error prescribing and shorten ICU stays. In the ICU, AI can guide personalized ICP targets based on autoregulatory function, not just generalized CPP thresholds. For example, patients with intact autoregulation can tolerate higher pressures without ischemia, while others with autoregulation compromise deteriorate at normal ICP levels. AI can help detect those thresholds by integrating multimodal data, ICP, partial oxygen, brain oxygen pressure, cerebral and cerebral microdialysis, and EEG. These technologies do not replace clinical pathways, they refine them. They help us ask better questions. Is the patient on the right sedation plan? Are we being too aggressive with therapy or not aggressive enough? And can we anticipate a complication before it occurs? For students and trainees, AI becomes a clinical reasoning partner, showing how treatment decisions might vary between two superficially similar patients. For nurses, it offers real-time insights into titrating therapies, interpreting vital signs, and escalating concerns early. For families, it allows care teams to present clear, data-driven options, improving communication and trust. In essence, AI supports what the best clinicians already do: tailors care to the person, not just the diagnosis. But it scales that wisdom across time, space, and complexity, helping even less experienced providers make high quality, patient centered decisions. Real time monitoring and decision support. In the ICU, data flows continuously. AI-enabled devices provide 24/7 analysis of brain trauma management data, such as cerebral perfusion pressure, intracranial pressure, mean arterial pressure, and brain tissue oxygenation, ventilator settings, lab results, EEG findings, and medications. Humans can only process so much at once. AI can gather, synthesize, organize, analyze, and make conclusions about multimodal critical care data in real time. By real-time synthesis of ICU data streams, AI systems can detect patterns, trends, and impending crises before they're apparent to a human observer. Clinically, these systems are not, quote, set and forget, unquote. They learn. Over time, their predictive accuracy improves based on local patient data and user feedback. For nurses, AI-powered dashboards reduce cognitive load by integrating charting, monitoring, and alerts. For trainees, they model reasoning and clarify cause-effect relationships in real time. For families, the visible interface supports transparency and reassurance. Ultimately, AI becomes the second brain in the ICU, not to override the clinician, but to make the complex understandable, the invisible visible, and the urgent undeniable. For example, AI algorithms can monitor trends in ICP and CPP and predict intracranial hypertension before it occurs, allowing for earlier intervention. These models adjust for other variables like age, comorbidity, sedation level, and autoregulation index. For example, AI-assisted ICU tools flag critical changes like cerebral herniation risk before clinical deterioration occurs. Wearables and bedside integration can detect trends, deterioration, and therapy response. AI-powered EEG wearables can monitor neurologic activity in TBI or stroke patients, tracking physiologic trends and responses to therapy, alerting clinicians to abnormal patterns and deterioration. Decision support. AI systems can also act to be clinical decision support tools, offering care teams diagnostic suggestions such as ICP crisis due to hydrocephalus or vasogenic edema, therapy reminders, such as when to resume DVT prophylaxis after EVD placement, treatment impact simulations, such as what happens if we drop PEEP versus increased sedation, tailored targets, such as individualized CPP, sedation depth, and ventilation strategy, cognitive load reduction, dashboard summaries to streamline workflow and alerts. Robotics and AI in TBI neurosurgical intervention. The operating room is no longer just the domain of the surgeon's hands. It's becoming an augmented environment where robotic precision and AI-driven intelligence support the most delicate and high-stakes procedures. In traumatic brain injury, this means faster, safer, and more accurate craniotomies, hematoma evacuations, and shunt placements, often in anatomically challenging or time-critical contexts. AI-guided navigation systems now integrate in pre-op imaging, CT and MRI, intraoperative neurophysiological monitoring, and real-time visual tracking. These platforms assist with trajectory planning for catheter or screw placement, target localization of hematoma margins and eloquent cortex, and avoidance of critical structures such as vascular or functional zones. Robotic arms provide mechanical steadiness beyond human capacity, particularly valuable in frameless stereotaxis or minimally invasive approaches. These platforms reduce tremor, optimize ergonomics, and can maintain exact positioning for hours without fatigue. In teaching hospitals, robotic systems offer automated data recording and movement capture, providing trainees with instant feedback and performance metrics. AI-driven robotic assistance in the OR can also predict intraoperative complications such as swelling, bleeding, or hypertension, simulate alternative strokes approaches mid-procedure if findings change, and optimize closure and flap replacement by referencing outcomes data from similar patients. Early studies show that robotic-assisted procedures may reduce operative time, infection risk, and postoperative complications, though much of the data is still evolving. From the bedside to the OR, AI is no longer just reactive. It's proactive, predictive, and precision-oriented. It augments the surgeon's experience, safeguards patients, and shortens the learning curve for the next generation. AI and neurorehabilitation after TBI. After the acute phase of traumatic brain injury, the long road of recovery begins. And just like in the ICU or OR, AI has a role in neurorehabilitation too, in guiding therapy, predicting outcomes, and personalizing care. One of the most transformative applications of AI in rehabilitation is in cognitive and motor recovery programs. AI-powered systems can adopt therapy in real time based on patient performance, track subtle improvements in function that human observers might miss, provide immediate, tailored feedback to patients. For motor rehab, AI is integrated into robotic exoskeletons and gait training systems, adjusting support and resistance levels based on neuroplasticity markers and EMG data. These systems increase intensity while minimizing fatigue and injury. On the cognitive side, virtual reality and AI-driven gamified therapy platforms allow for individualized attention training, memory tasks, and executive function exercises that grow more challenging with patient success. This makes therapy more engaging and less dependent on therapist availability. AI also powers predictive models, helping rehab teams anticipate which patients are most likely to benefit from intensive therapies and which may plateau early. This can improve allocation of resources and set realistic expectations for families and patients. Perhaps the most exciting frontier is brain-computer interfaces. These AI-enabled systems decode brain signals and translate intention into movement, allowing some patients to control robotic limbs and cursors or communicate with thought alone. Early applications in TBI, stroke, and spinal cord injury show promise. Finally, AI supports continuity of care. By mining electronic health records, it can suggest therapy modifications, flag missed appointments, or even detect early signs of depression, fatigue, or caregiver burnout, prompting intervention before setbacks occur. For patients, this feels like care that remembers them, care that adapts, evolves, and truly sees their progress. For providers, AI acts as a multiplier, extending our reach while preserving the human connection that remains essential to healing. AI in prevention and early identification of TBI chronic complications. While much of traumatic brain injury care focuses on acute management and rehabilitation, some of the most exciting developments in AR are happening upstream in early detection, risk prediction, and even prevention of injury and deterioration. In pre-hospital and athletic settings, AI-enabled wearables embedded in helmets, wristbands, or smart clothing can detect dangerous acceleration-deceleration forces, assess motion trajectories, and predict concussion risk before symptoms become obvious. Some devices trigger alerts or recommend removal from play automatically, enhancing safety in real time. In high-risk populations, like older adults or patients with prior TBIs, AI tools can predict fall risk by analyzing gait, balance, and subtle changes in behavior. These systems can then suggest targeted interventions, physical therapy, environmental modifications, or medication reviews. For those already injured, AI can help identify patients at risk of deterioration before it occurs. By analyzing electronic health records, imaging trends, vital signs, and prior events, models can flag individuals likely to suffer delayed hematoma expansion, hydrocephalus, or post-concussive syndrome. These early warnings allow clinicians to escalate monitoring or intervene sooner. AI can also help with TBI-related neurodegenerative disease detection, particularly in patients with chronic TBI or repeated mild injuries. Algorithms trained on speech patterns, typing cadence, reaction time, and functional MRI changes can detect early signals of TBI chronic complications such as chronic traumatic encephalopathy, Parkinsonism, or cognitive decline, sometimes years before traditional tools. In public health, AI helps identify hotspots for injury, from poorly designed intersections to nursing home fall clusters, enabling proactive policy changes and resource development. For providers, AI offers earlier warning. For patients, it offers longer protection. And for society, it offers a path from reaction to prevention. AI and brain health enhancement beyond injury. Artificial intelligence isn't just about treating brain injury, it's also about enhancing recovery, cognition, and long-term brain function. This area, sometimes called brain optimization, represents a bold new frontier. In post-TBI patients, AI can track cognitive performance across time, attention, memory, language, and executive function, identifying subtle improvements or declines that may guide therapy. For example, when patients plateau in rehab, AI tools can suggest new approaches tailored to their neurocognitive profile. In healthy individuals or those with mild deficits, AI-driven cognitive training apps and neurofeedback systems offer personalized exercises to strengthen neural pathways. These tools are adaptive. They change based on performance and integrate real-world challenges like stress, multitasking, and distraction. AI is also enabling closed-loop neuromodulation systems, where stimulation of the brain, such as via transcranial magnetic stimulation, or implanted electrodes, is automatically adjusted based on live brain activity. These systems have shown promise in enhancing learning, improving mood, and reducing symptoms of depression or fatigue after TBI. For patients struggling with fatigue, insomnia, or mood instability, AI algorithms can analyze sleep, activity, diet, and biometrics, and recommend small personalized changes to improve overall brain-body integration. For example, tools like Muse, brain sensing headbands, adapt brainwave feedback for mental clarity and recovery. Some researchers are even exploring AI-supported coaching platforms that provide daily cognitive and emotional support, including reminders, motivation, affirmations, and structured planning, to help patients feel more confident and connected during long recoveries. While some of these tools are still in development, their underlying goal is clear: to help every brain work better, whether healing from injury or aiming for lifelong resilience. Ethical considerations in AI and neurotrauma. As artificial intelligence takes on more roles in patient care, we must ask not only what can it do, but what should it do? Nowhere is this more important than in neurotrauma, where decisions often involve vulnerable patients, time pressure, uncertainty, and irreversible consequences. One of the primary ethical concerns is transparency. If an AI tool recommends withholding surgery or withdrawing care, can it explain why in a way that is understandable and meaningful to patients and families and providers? Many current algorithms function as black boxes, making it hard to assess their reasoning. There's also the issue of bias. AI systems are only as unbiased as the data they're trained on. If historical healthcare data contains disparities based on race, age, disability, or socioeconomic status, AI may perpetuate or even amplify these inequities in decision making and prognostication. Autonomy is a key concern. When AI is used in communication, for example, generating language for consent, prognosis, or treatment options, we must ensure patients and families retain meaningful control and can challenge or reject AI-informed recommendations. In the OR or ICU, AI might optimize workflow or predict deterioration, but what happens when a clinician disagrees with AI? Who is accountable? What are the standards for override or shared authority? These are not theoretical questions. They are already arising in legal and medical ethical forums. For research and education, we must consider privacy. Continuous monitoring, facial recognition, and behavioral tracking may enhance care, but they also raise concerns about surveillance, data ownership, and consent. Finally, we face a larger question. Will AI narrow or widen the gap between high and low resource settings, between tech-savvy hospitals and rural clinics, between highly engaged patients and those who feel marginalized by complexity? As clinicians, educators, and developers, our task is not just to deploy AI, but to shape it, anchoring every algorithm in dignity, equity, and shared humanity. Research, advances and future prospects in AI and TBI. The research landscape for artificial intelligence and traumatic brain injury is expanding rapidly, with innovation spanning from diagnostics to prognostication, intraoperative support, rehabilitation, and long-term monitoring. Recent advances include AI-enhanced CT and MRI interpretation, ICU data synthesis for ICP prediction, personalized outcome models, adaptive neurorehab, and ethical frameworks for critical care AI. Future prospects include explainable AI for trust and decision making, federated learning across institutions, digital formatting from daily behavior, AI-assisted documentation and communication, and integration with genomics and brain networks.